It's very important to understand that in this heart failure symposium that we are now talking about a multidisciplinary disease, whether it's diabetes or heart failure. Heart failure belong to cardiologists, and diabetes is now talking about heart failure, and we've got drugs which the cardiologists are trying to steal away from the diabetologists, like the SGLT2 inhibitors, and diabetologists are now using ARNI. So we've got to understand that this multidisciplinary approach has to be followed, whether you are a cardiologist or a diabetologist. For maximal benefit in people with heart failure, you need to use a combination therapy, and these important therapies heart failure. And Dr. Devra, you very nicely talk about clinical inertia of what you think are the most important factors of clinical inertia when you see that these therapies have not been either initiated or up titrated in your practice. Dr. Deora and Dr. Mathur, can we see both of them?
Right.
Right, Dr. Mathur.
Yeah, sure.
Yes.
So I think this this question is very much pertinent to today's problem, because the inertia is related both to physician and to the patient. As Dr. Devra has very well enumerated the causes of not starting earning, and the financial reasons comes very high upon it. So this may be one reason why patients are not accepting. Now we need to convince the patient about its benefit, and for this we first need to get convinced that this is a beneficial drug, and this is the purpose of all these exercises we are doing today also. So first of all, as a step one, we physician needs to get convinced that ARNI is useful over and above ACE inhibitor and ARB, and then only we'll be able to convince our patients. And we all know that if we sit and explain these all benefits to the patients, most of the patients are going to accept it, until and unless there are few minority of patients, well, not minority, a significant number of patients who cannot afford these medication. So on the part of industry, we would request to bring down the cost, so that these, at least these very useful drugs, which are life-saving in a way, so they can be accessible to most of the patients. As far as physicians are considered, we need to accept that many people are now initiating beta blockers and ARNI, but then most of us physicians are not up titrating them to the maximal tolerable doses. So the causes, again, like Dr. Surender has told, that it might increase the work of the doctor to advise him investigations and to get a proper follow-up, and a fear, ill-founded fear, that if I'll ask my patient to come even after every 15 days, I lose my patient. So maybe they are true to some extent, but if you see the benefit to the patient, I think the most important thing is that.
Is Dr. Deora also here? Probably he's not. Anyway, now Dr. Mathur, another issue that I would probably like to pick up is, you've got these type 2 diabetes, HFrEF, two important trials which have become the focus, DAPA-HF and Emperor Reduced. And then you had the Paradigm trial. So the diabetologists, endocrinologists are very fond of talking about the DAPA-HF and Emperor Reduced. So SGLT2 is in focus, and you have the Paradigm trial, but the author for two trials was the same, John McMurray, DAPA-HF and Paradigm. And Emperor Reduced was Milton Parker. Interestingly, in Circulation in 2021, they've come out with a document, how do you sequence therapies for heart failure? I want to have your opinion on this. They say start with beta blocker and SGLT2 inhibitor, add ARNI, and then add MRA. But do this all in a span of 4 or 6 weeks with proper up titration. Would you like to comment on this latest document that these two people, the authors of two most important trials on heart failure, have come up with?
This debate is there right from series 3 trial. that which agents to be started first, beta blocker or ACE inhibitor. When I'm talking about when SGLT2 inhibitors probably were not there. So this is the debate we are doing right from that era when CBIS-3 trial was done. And we have reached up to at least a consensus that we have to start beta blocker and RAS inhibitor, be it ARNI, ACE inhibitor or ARB, together in a permissible doses. So I would also, now the only thing is we have to be very, very, you know, we have to keep it in mind that SGLT2 inhibitors probably they cannot be started when the patient is very sick because of the risk of non-hyperglycemic ketosis, right? So I would rather say that if your patient is having acute decompensated heart failure with reduced ejection fraction, maybe 15%, 20%, you can start with beta blocker and ARNI, and during this in hospitalization phase only, you can add SGLT2 inhibitor probably the second or the third day. That doesn't say that SGLT2 inhibitor is not that important. I do not want to undermine the the role of SGLT2 inhibitor, but just because I want to be doubly sure that my patient doesn't go into ketosis, because this has been one contraindication, or say not contraindication, precaution to start SGLT2 inhibitor, that they cannot be started in sicker group of patients. So I would say that we can start with beta blocker and ARNI on the day one probably, and as the day passes on before hospital discharge, we can always introduce SGLT2 inhibitor. Importantly,
Perfect.
SGLT2 inhibitors, they do not require dose titration. You start with 10 milligram and stick to 10 milligram. So
Yes.
that's, if you start during second or third day of hospitalization, I think you are done with your treatment plan.
Do you think that, both these agents, as I mentioned in my talk, all these agents are more disease modifying agents? So do you
Yes,
think,
yes.
is there any study to show that like the SGLT2 inhibitors, which increase ketone body formation and improves myocardial energetics, the ARNI also does something like this, or is it just acting, decreasing fibrosis, decreasing cardiomyocyte hypertrophy, etc.?
Yes, so ARNI has shown to improve reverse remodeling as well. So not only that it affects renal functions, it affects heart's function, and it affects endothelial function as well. So ARNI has got effect on all the three parts. So not only that it improves endothelial dysfunction, it improves renal parameters and renal functioning, it improves reverse remodeling as well. So ARNI, I would say, has got a better spectrum of action in comparison to SGLT2s or probably other agents.
But the the studies with empagliflozin and on left ventricular mass have shown that they also probably have enough evidence to show structural changes and structural benefits that they get. Now, one last question before we wind up, because it's 10:59, we have to close at 11. Do you find that this agent is as useful in acute heart failure and chronic heart failure?
So again, there is no reason why I would not take this agent as a useful in acute heart failure, because we know that not only it improves, as you have said, that it reduces the LV mass, but it has got very good diuretic properties as well because of glycosuria associated with it. So there is no reason that I would consider it a lesser useful agent in acute heart failure. As far as I keep that ketone body formation in my consideration, I would be happy to start in acute phase.
Right. Just keeping in mind our electrolytes, our potassium levels, creatinine levels, EGFR when we are using ARNI and SGLT2 inhibitors. Of course, we've got the cutoff of 30 for SGLT2 inhibitors, and I think that's the cutoff for almost all these. So let me thank Dr. Meenavat for this invitation.
Can I ask a question, sir? Dr. Nigam, sir, I want to ask a question.
Sure, please.
I want to ask to Dr. Ro, this is for Dr. Rohit Mathur.
Yes,
Yes,
please.
sir.
Wonderful talk, excellent talk, no doubt about it. It was expected out of you. My basic question is the most important cause of heart failure is hypertension, and all hypertensive patients are on thiazide diuretics, and subsequently when the patient develops heart failure, the thiazide diuretics go into the back seat, but still a drug like metrolazone is used whenever there is a situation of congestive heart failure. So I want to know from you, what are the limitations of thiazide diuretics, at what BFR we should not use thiazide diuretics, and out of available thiazide diuretics, which one you would prefer? Thank you.
So for this, I think this is out of context question. If the organizer can permit me, I can answer these questions.
You'll have to check with organizers, because we are crossing the time limit, and I don't think
That's what
this
I'm
is
asking. If organizer can permit me, this is out of context question. So if organizer can permit me, I can answer. Can I go ahead?
Yes, sir, please go.
Right. Thank you, sir. So now what we are talking about is different diuretics. So you need to see the pharmacokinetics of thiazides and loop diuretics. You know why thiazide diuretics goes into background therapy when the LV ejection fraction is poor? It is purely because of two things. Because thiazides are milder diuretics than a loop diuretic, right? The strongest diuretic is a loop diuretic. The second thing is, you know why furosemide and why torsemide is given advantage over furosemide? Not only because it is more potent, it has got a longer half-life. The problem with furosemide alone is that if you give furosemide in an OD dose, your patient is going to have rebound sodium reabsorption, because furosemide has got a shorter half-life. It will act for 4 to 6 hours only. So when you are using a diuretic for especially hypertension purpose, you need a diuretic which acts for longer duration. Thiazides have got a longer half-life. First of all, they are milder diuretic, which will cause a bit more epiuresis if you give them a when you need more intense volume reduction, you will need a loop diuretic. Again, having said this, I do not undermine the importance of thiazide diuretics in LV dysfunction as well, because once your patient is having diuretic resistance, like I said in my slide, that if your daily requirement of furosemide is going over 80 milligram per dd per day, then you need to add thiazide diuretic, because this will provide you alternate site of action. Loop diuretics will act on loop of Henle only, thiazides will act on distal tubules. So thiazides are used in antihypertensive purpose because of their long half-life, because of their bit milder action, but they are not useless in LV dysfunction. You might still use them whenever your need of diuretics is increased. I think I'm clear.
My question was use of metrolazone. Metrolazone is typically used for congestive heart failure only, and there are limitations of
So metolazone is a loop diuretic, sir. It is not a thiazide diuretic.
the thiazide diuretic. It is not.
It's not a loop.
Sir, okay, but metolazone is quite a potent diuretic. And it is used only in conjunction with the furosemide or torsemide. It is not used or standalone, because when you want to provide other alternate site of action in distal convoluted tubule, when your loop of Henle is maximally working, still you are having high sodium, then you want to add another site of action. You can use metolazone, or you can use the hydrochlorothiazide or chlorthalidone.
I agree with you. The limitation of thiazide diuretics is they cannot be used beyond when the eGFR is reduced to less than 30. There is no point in using thiazide diuretics.
Ashok.
I think we finished this session here.
Yes, thank you. Thank you, Dr. Mathur and Dr. Deora. Let me thank Dr. Minawat for this invitation to speak and moderate this session on heart failures.
Thank you very much, sir. It has been wonderful talking to you and hearing both, all three of you. And the panel discussion has been ultimate. Thank you very much, sir. Thank you for the time.
Thank you very much.